exit full screen and go back to you guys. Where am I? Stop sharing, and I'll find you. There we go. So you guys saw that pretty well, right?
It was perfect.
Yeah, no
Okay.
problem.
Yeah, that's Clayton's voice, the surgeon doing the whole thing. I thought he did a pretty good job of doing a circumferential dissection around the gallbladder anyway. Certainly that's a piece that a lot of people seem to forget is a critical part of the CVS. But mostly it was just the idea to get the idea across that if you really want to find out what's going on, if you need a roadmap, got to find a way to inject. And if you can't find the cystic duct, it might be that might be a sign you ought to stop anyway, right? If if you can't find the cystic duct, that's a signal life could get very rough if we keep going forward, right? But if you can find the gallbladder, and if you can dislocate that stone out of the ampulla and inject into the ampulla, you get yourself a cholangiogram. Doesn't mean you should still proceed, but at least you can certify you haven't injured anything. And if you're going to quit, okay, I'm going to quit, but at least I know the anatomy and so forth. See who's in the chat here. Okay. Oh, yeah, that's a good idea. So when we're not presenting, remember to turn off all our stuff. There is in the chat, you can see, have you seen the chat, Matt? There's the agenda. You're first.
I sure do.
Yeah, and Sal is second.
Yep.
Okay, and then Adnan, and then Dana. Now, I don't have a
I'm sorry.
cheat sheet with your bios on it. And so maybe as I introduce you and you start to give your session, you do a little, I'm Dr. Matt Bloom. This is what I do, where I work, a couple seconds, a little background about yourself so that the people know who you are, where you're working and so forth.
And you said about 20 minutes each, right?
And
Is it?
Adnan, should we call an Uber and have them bring a coffee or what?
and you said we have visiting guests from the Netherlands, and I took them out for dinner last night, and they sure freaking can party. Oh my God, I feel exhausted. And you want us to go for 20 minutes each? Is that right?
That's what Betty put in the agenda, yeah.
Okay, and
About
that's
20 minutes or so.
and then we're gonna all do questions at the end.
Yeah, if you go over a little bit, it's no big deal. And I mean, the rest is for discussion. And hopefully people will ask you questions, not just about reading these things and using the instruments, but about your decision-making processes.
You want us to take questions after each one of our things, or
no, I can hardly hear you, and I'm not sure why.
Oh, is my okay? Well, that's not
Is
good.
everybody else having trouble, or is it just
I hear him just fine.
I hear him okay.
you do? Okay. Now
Yeah.
Zoom is fooling around with me.
Richard, when I'm done, do you want me to hand the talk back to you so you can introduce the next speaker?
Right, that's fine.
Okay.
That'll be fine.
Is this any better, Richard?
This happened to me the other day. I'm gonna I think I might sign off and sign back in. I don't know, because I can't hear Adnan. I just hear this garbled distorted tone from him, and it's not his doing. Let me go over to settings on the audio and see if I can do anything with it. Background noise removal, suppression. I don't know, I'm afraid to back out and come back in, but I might just have to do that because I can't hear him at all. Let's see if I can make sure that I have the ticket to get back in. I think I do. All right, I'm gonna back out of here and come right back, okay?
Anyone else have a busy day today?
Absolutely crazy
Yeah.
day.
The usual.
The usual, exactly. Although you look
Yeah.
well rested, well dressed like usual, Sal.
It's it's coffee, good lighting. It's all about lighting. It's all we're getting ready for another hurricane, which is kind of shocking.
Oh,
I know this kind of popped out of nowhere. I was walking out this morning and they were putting up we have this like seawall that goes around the hospital. It's actually pretty neat because the hospital's on an island. And I was like, what is going on? Sure enough, look at the news and there's another one coming up. But I think we're going to be okay. I think it's going to go west of us, so we should be fine. But
Hey, Betty, I can't turn on my video. But say something again, Adnan. I think I could hear you well.
yeah. Can you hear me now?
Perfect. Yeah. Yeah.
Yeah, perfect.
Zoom was fooling around. Still can't get my video going. Because we should probably get started, but
Yeah, I
Betty,
think so.
Betty, turn on my video. You are the co-host now. Okay, so that did it. There you go. Okay, Betty, are we ready to go? Can we do the deed? Yes, we can. Okay. So I think we're going live. So, hey, welcome to everybody. Fortunately, the panel and I have had a chance to get to know each other and test our equipment. I'm Richard Vazquez. I'm simply the panel moderator, facilitator. Brian Davis, who's not on the call and not right now, from our Safe Coley task force, is really the fellow who organized and selected the speakers and did just a great job of it. So we'll go through each of the talks, and I think that the order of them is that Dr. Bloom is going to go first. My chat has been cleared, by the way, since I came back up. So he'll go first and then pass back to me. And then I think who's going next? Is it you, Sal? Sal's next, then Adnan, and then Dana. Okay. So thanks to Betty at BSC Management for helping us get through all of this. I don't think any of this would be possible without Betty and the work that they do to keep us honest and on track. So we're going to get going. Dr. Bloom is going to introduce himself and speak about essentially contrast cholangiography. Matt, please take over.
Well, good evening, everybody. Hope you've had a great day in the operating room today. My name is Matthew Bloom. I'm an acute care trauma surgeon at Cedars-Sinai, Los Angeles. I have the honor to talk to you tonight about contrast cholangiography, its rationale, technique, and interpretation of studies. Basically, this talk will be the who, what, where, when, why of contrast studies. And just a little bit of history. First, prior to the advent of biliary imaging back in 1895, when X-rays were first invented, bile duct exploration, of course, as open surgery, was based on direct operative palpation of the bile duct. And this resulted in lots of unnecessary bile duct exploration. Roughly half the cases, missed and retained common duct stones were the greatest cause of morbidity and mortality in biliary disease. You probably know the name Maritzi from Maritzi syndrome, a stone at the gallbladder neck that presses on the common hepatic duct and can fistulize. But Maritzi is important because he introduced operative cholangiography by adding in the use of contrast material, which was a major technological advance and reduced both the rate of negative bile duct exploration as well as the incidence of retained bile duct stones after an exploration. 1974 comes along and ERCP starts raising its head and really takes over, because static cholangiography, which is, man, this is open surgery and this is X-rays and film X-rays, where I remember when I was a resident, x-rays in a cassette that you would take a film and then go get it developed and then go get it up and hang it on a light box, as you can imagine, took a lot of time to do. And these studies weren't very accurate. By the time laparoscopic surgery came along in the 1990s, surgeries weren't really trained to perform cholangiography, nor did they really have the skills they needed to do laparoscopic common duct exploration. And as a result, there was a huge surge in the number of ERCPs that were obtained preoperatively, and the majority of these studies were negative. The stones that were seen were removed by endoscopic means. So now, in a minimally invasive era and a robotic era, why should we perform a cholangiogram? Well, first reason is to see the normal variants of anatomy and to stay out of trouble. When you look at Netter, Netter shows a beautiful picture of a cystic tree that goes up and down on the midline and a gallbladder coming off at a right angle on a cystic duct. But the reality is that's only 17% of the time. That's less than 18%. So more often than not, that's not the case. And this cartoon illustrates 8 common variations: a low insertion of the cystic duct in the common hepatic duct, a parallel cystic duct, a high insertion, a cystic duct that drains into the right hepatic duct, a very long cystic duct that makes its attachment to the common duct behind the duodenum, absence of any meaningful cystic duct at all, and the last 2 represent cystic ducts with course anterior or posterior to the common hepatic duct when it joins it. So that's one reason to do a cholangiogram, to see normal anatomy. And another reason is if you do a cholangiogram and it's normal and the patient comes back to you in clinic and still has epigastric pain, you don't need to do any other fancy imaging studies post-operatively. You can tell them it's not a biliary tree problem and probably refer them to a different type of medicine like GI. A second reason to do cholangiography is to allow for the real-time identification of common bile duct stones, which can immediately be addressed at the time of operation or immediately after. This session as a whole, we're not talking about lap common duct exploration. It's a separate topic. But in general, doing a laparoscopic common duct at the time of cholecystectomy versus an ERCP means the patient typically has a shorter hospitalization, gets less anesthetic because there are fewer separate procedures, and is overall less cost to the hospital. Having said that, many hospitals don't have next day availability ERCP. So a lap common duct is a great technique to learn, and a precursor to that is intraoperative cholangiography. And here's a very simplified cartoon of a transcystic laparoscopic common duct exploration. The last reason is for the prompt recognition of a ductal injury, either erroneously placed clips, a transection, which can be identified and corrected at the time of the original operation, which results in markedly better better outcomes. As you know, it's a very big deal if you get a bile duct injury. It's a disaster for the patient and for you if you don't recognize it at the time of the operation. Recall there's a tremendous morbidity with delayed recognition of a bile duct injury. Death rates that would be from 0 to 3% if you identify at the time of operation go to 5 to 15%. Long-term stricture formation goes from 10% to 50%. Biliary cirrhosis in the future goes from 3% to 25%. Need for multiple operations goes from 5% to 40%. And quality of life for these patients is horrible. So as you know, if you get a ductal injury that you identify at the time of operation, call for help, call an HPB surgeon, a liver surgeon, a transplant surgeon. It's not unheard of, if these are not available at your hospital, not unheard of to make some phone calls and transfer the patient directly from your operating room to an operating room at a different facility that has a specialty trained surgeon. They'll probably tell you just to put a drain, don't do anything else, don't touch it, don't try to fix it. But it's so important to recognize a ductal injury if it happens in real time. So I know it's late at night for lots of you guys. You don't want to hear about literature, but if you're going to quote one study, the Swedish registry study is the one to know about. And the reason it's spoken about so often, it's really the best study we have in Sweden, socialized medicine, pretty contained population, with excellent record keeping. This study looked at over 51,000 patients who underwent laparoscopic cholecystectomy. And when they just compared the group of surgeons that did routine cholangiography versus no cholangiography, that study, in its retrospective fashion, showed that whereas with routine cholangiography, the bile duct rate was 0.3%, it was doubled when you did not do cholangiography. When you did cholangiography, early detection of injury was 84% versus 37%. In their database, they showed fewer reoperations and long-term outcomes better. They showed that IOC is pretty quick to do, 15 to 30 minutes, and concluded, of course, that routine cholangiography is a safe approach, even in low-risk cases. So then the question is when to do it. You could either do it all the time, routinely, or you could do it selectively. And this is probably just a good time to just slightly deviate and talk about another important surgeon who actually passed away in the past, earlier this month at the age of 103. He was a surgeon at my institution, Cedars-Sinai. And truly, he's the most remarkable person I've ever met. He's particularly germane to tonight's topic for a couple reasons. First, he was one of the founders of SAGES and a past president. As far as laparoscopic surgery, Dr. Bursey made the first really usable laparoscope by putting a Hopkins rod lens system, which could both transmit enough light into the abdominal cavity as well as return a meaningful image into an eyepiece. Then he attached a television camera to the eyepiece so that the black and white images could be seen on a TV screen. And that, as you can imagine, made laparoscopy actually viable as a way to perform an operation. Separately and directly relevant to this talk was that Dr. Bursey was one of the first to use a fluoroscope to obtain real-time images of the biliary tree instead of static x-rays and all the time it takes to make an x-ray, get it developed, and see it. So that he made cholangiography a really slick and rapid procedure. And lastly, Dr. Bursey personally did a tremendous amount of work in surgery education at SAGES of both practicing surgeons and of residents. So the question then remains, when do you do this cholangiography? Do you do it routinely or only when you need to? And the problem I find when I ask surgeons whether they do it routinely or selectively guys say, yeah, I do it selectively. I select not to do it. And that's not a great attitude. The selective guys really aren't doing it that often. Let's look at reasons to do it selectively versus routinely. Selective cholangiography is done when the surgeon thinks ahead of time there's going to be stones. Well, I had elevated liver enzymes before going to the operating room. Maybe my ultrasound showed bile duct dilatation. I'm going to do a cholangiogram on this case. But routine cholangiography, if you do it every time, you're going to find the number we typically quote is 10% of the cases will have common bile duct stones. Especially surprising are on patients when there was no indication preoperatively they would have a common duct stone. Miraculously, you find it. And that's, you wouldn't find it if you weren't looking for it. The benefit of finding it, of course, is to get rid of postoperative complications such as biliary obstruction, cholangitis, and pancreatitis. So many people have written that routine IOC is a good thing, and it picks up stones in asymptomatic cases. Now, that's just finding of common bile duct stones. Once again, let's look at bile duct injuries. From multiple papers, we have routine cholangiography, excuse me, reducing the rate of bile duct injuries, first of all, from 0.2 to down from 0.4 to 0.5%. Immediate recognition, super high. Mortality with this immediate recognition, super low. Reoperation rate, super low. And once again, the opposite, when you do it selectively, delayed recognition in up to 40% of cases, which has tremendous morbidity, mortality for the patients. A mortality rate on the order of 10-15%, higher rates of leakage, peritonitis, reoperations, rate of 20 to 40%. So that's a reason to do cholangiography every time. Performing a cholangiogram doesn't have to be a lengthy, frustrating procedure. Because we have C-arms that are readily available in most hospitals, when performed routinely, cholangiography is incorporated pretty seamlessly into the flow of the operation. The equipment on the table is ready to go. The operating room staff knows how to set it up and how to help you. The radiology techs know how to position their equipment. Things get done pretty quickly. And by doing it every time, the team really gets trained up and the procedure gets done as a matter of course. So if you're starting a cholangiogram program for the first time or you're not doing it routinely, it's good to have a couple things. A dedicated instrument tray is super important. It's a nice idea if you're introducing any procedure to the hospital to make a laminated photograph for the techs, for all the equipment and how it should be set up. It's a good trick no matter what you're introducing to your hospital, and to have a printed list of all the material that should be on the tray. You're going to prepare a 50-50 mixture of saline and contrast material. And there's contrast like Omnipaque or Visipaque, and you're going to fill 2 separate 30 ml syringes with the mixture connected to a 3-way stopcock. Ideally, you'll have extension tubing that's on the order of 96 inches in length, which allows you to stand far away from the patient. And you're going to make a 3rd syringe filled with saline. You're going to label all these syringes. You can connect all your tubing up. And so the utmost important to make sure that the tech gets rid of all the air bubbles in the system, all the air bubbles in the tubing, and air bubbles tend to collect in the syringes themselves. And it's so important to get rid of it and not flush it into the patient. If you're doing a laparoscopic cholecystectomy, typically you're going to introduce the catheter through one of the upper right subcostal 5mm ports. There's a variety of catheters you can choose from, but a 4 French or 5 French end-hold urethral catheter works really well and is very inexpensive. But if you do a urethral catheter, you're going to need some type of device, such as an Olsen clamp, that will fixate the catheter around it. Or alternatively, this is a different type of device that delivers the same urethral catheter. You can put a clip on the proximal cystic duct, distal cystic duct. There are other types of catheters, such as the slightly barbed taut catheter. And this is nice because when you put a clip around the duct around this, it doesn't compress because it's hard metal. It doesn't compress the catheter like a plastic catheter might. Or you can use a balloon catheter, which would secure itself by insufflation against the cystic duct wall. Or a Kumar clamp, which we'll show separately, is another nice idea. Another way to introduce a catheter through the abdominal wall, if you're not going to use a port, is to place a 14 French angiocatheter through the abdominal wall into the right lower quadrant. That's what I do when I do a cholangiogram when I'm doing robotic cholecystectomy, because I just want the catheter itself in the body. So let's see if I can run this movie. Good. So once the cystic duct is identified, you're going to place proximal clips, or surely one or several clips, to prevent backfilling to the gallbladder. You're going to make a partial anterior ductotomy proximal to that clip, taking care not to transect the duct entirely. Ideally, bile is going to start flowing out of the ductotomy, but if not, small stones can be milked proximally into the otomy by sweeping the porta hepatis and the common bile duct to get all the grit out of the cystic duct. If this ultimately doesn't produce bile, you can squeeze the cystic duct itself gently in a distal to proximal direction using a blunt grasper to milk stones towards the opening, and then you should do your sweep again. While placing that cholangiocatheter into the cystic duct, you should slowly drip saline into the catheter so that air and carbon dioxide doesn't go into the duct. It also helps you get the catheter in by distending the duct a little bit. And as I said earlier, once the catheter is secured, you'll clip it. The saline syringe should be carefully replaced with the second 30 ml contrast-filled syringe to not introduce bubbles into the stopcock and cholangiogram tubing. You should watch the injection of saline to make sure there's no leaking or extreme resistance. And that happens quite often, actually, you get a little bit of leaking the first time. If there is, take the catheter out, put it back in. If you use a cholangio fixation forceps like an Olsen clamp like this, it's a nice idea to prop the handle against a pile of towels or clamp it to the sterile drape to make sure it doesn't get pulled. The duct doesn't get pulled. After you secure the cholangiogram clamp or the catheter and the sterile drape, the C-arm should be brought in from the patient's right side if possible. By this time, the table should have been brought down to a neutral position. You want to get out of reverse Trendelenburg, which is used for the operation, and then roll the C-arm 10 or 15 degrees over the top of the patient. Because remember, the biliary tree is a midline structure, and by rotating the C-arm, you're taking the patient's vertebrae out of the plane of the image so that the biliary tree isn't superimposed over the vertebrae, which makes it easier to read the study. And a nice trick that you can do is with this drape, I usually like to twist up to twizzle the drape right over the patient's xiphoid process, which makes a good target for the fluoroscopist to take their first shot. If you've seen this, you might have to take 1 or 2 or 3 shots to get the C-arm right where you want it to be to get a good image. And that's a nice way to get it right the first time. So what makes a good cholangiogram? Well, there are really 4 things that you want to see for a completed cholangiogram. You want to see opacification of the cystic duct, and then the common bile duct and common hepatic ducts. You want to make sure both the right and left hepatic ducts get opacified, and you want to make sure that contrast goes through the ampulla into the duodenum. So this is a near perfect image. And what makes it a perfect image is the cholangiogram catheters should be on the upper 1/3 of the image. Upper third top of the image is a good place to see the tree and the bifurcation. The vertebral body should be just to the right of the midline of the image. And that's a good way to see the early filling phase at the distal common duct, where most of the stones are likely to be found. So, especially if you're taking a series of static images, which is, the C-arms have different technologies that I think we'll talk about further a little bit later tonight. But some allow you only to save, you can see live images, but only saved images or static images get kept or even sent to PACS. And especially if you're doing with that type of machine, at first inject only a few ml of contrast material under live fluoroscopy, and then save that image. You just want to save just a little bit, save it. If you inject too quickly, the contrast may obscure any filling defects from small stones. And that's another reason why you do 50-50 contrast material. You might think, I'm going to use full strength because stronger is better. You want 50-50 contrast, or contrast mixed with saline, because if a full strength column of contrast goes behind the stones, as it very well might, then you won't be able to see the stones anymore because the contrast itself is so dark. So actually, a lighter contrast mixture gives you better visualization. Under live fluoroscopy, we give additional contrast, which should fill the common duct distally, and contrast should flow pretty freely into the duodenum. Once again, if you could do it too fast, you might obscure filling defects from stones. You can magnify areas of interest with the C-arm to allow for early interpretation. And after dye is seen in the duodenum, you might need to reposition the C-arm to look at the intrahepatic region, because once again, you must see the left and right hepatic ducts. And that can be aided by putting the patient down in Trendelenburg to let gravity help pull the dye caudally. This is a final still image without magnification of the entire biliary tree and the duodenum, which concludes a good cholangiogram. Alternatively, you can do a cine cholangiogram, and we'll talk about those a little bit later also. This is a great cholangiogram, except for the fact there's no filling in the duodenum, which suggests there might be a big stone right there. Let's talk about techniques for difficult cases, because easy cases are easy, but difficult cases is where you really need to know what you're doing. Inflammation makes cases that come in through the emergency room very difficult. Be aware that the sequelae of inflammation can completely obliterate the hepatocystic triangle and Close triangle. If a normal study looks like this, with severe acute inflammation, you're going to have thickening of the gallbladder wall. It has a tendency to stick to the common hepatic duct. There may be fusion of the cystic duct to the common hepatic duct. I had a difficult case yesterday with a huge stone at the neck and essentially no cystic duct to speak of. And I'll tell you what I did about it in later slides. Be aware also that when you're doing lap chole, robochole, and it really shows up nicely on a cholangiogram, as we always give a lateral traction on the gallbladder, it's amazing how much you can distort the common hepatic and common bile duct and pull it towards you, especially with a short cystic duct. And you can imagine thinking that all this is cystic duct and putting making a incision in the wrong place or putting a clip along the wrong place. It's not nearly as craniocaudal as a cartoon from Netter would suggest. Briefly, we talked about a Kumar clamp is another way to get dye into the biliary tree, and we'll show videos in that later tonight. In this case, a clamp is placed at the neck of the gallbladder. The clamp has a built-in needle, and you can do a cholangiogram through that portion of the gallbladder. How else do you get dye into the biliary tree? Well, a subset of my patients come to me with percutaneous cholecystostomy tubes that I or my partner had placed on a previous admission or even earlier on that admission for a patient who was too sick to undergo general anesthesia at that time. This is an interesting cholecystogram because at this time the cholecystogram is pretty, shows a patent cystic duct, which probably wasn't the case when the tube was placed. In a perfect world, with resolution of acalculous cholecystitis, you saw this in clinic, you could pull this catheter and be done, except that because this wasn't replaced, usually we have these placed transhepatically through the liver so that when they're pulled out, the gallbladder bile leaks into the liver and doesn't really leak into the peritoneal cavity. In this case, if you were to pull it out, even though the gallbladder might be healthy, you'd be leaking bile into the peritoneal cavity. So this is a patient that probably would have the gallbladder taken out. But at the start of cases, if they have a cholecystostomy tube in, I shoot a cholangiogram through the tube because it's a great roadmap even before we get started. Alternatively, and this is what I did yesterday during my difficult case, I did a cholecystic cholangiogram with a needle into the gallbladder itself. And this is a picture from Dr. Bursey, but I did exactly this. We placed metal clips roughly in the area of interest and shot a cholangiogram that showed to us that our patient had no cystic duct to speak of to confirm that it was a difficult case. But it's a great trick to do. Towards the end of my talk, let me just go over pearls and tricks. If you have trouble getting the catheter into the cystic duct, well, first problem is, as you know, the duct has, first problem is you got to make sure you're in the true lumen of the duct and not a false passage. And that certainly happens, or that the catheter is not stuck in a valve. The internal valves of Heister can prevent the passage of a cholangiocatheter. So one thing you can do is carefully insert a micro scissor into the ductotomy, the scissor in the closed, and kind of push through the obstructing valve. Or you could try to sharply incise with the micro scissor the inside, chew it up a little bit. It may be easier just if your duct has been identified enough to just relocate your ductotomy on the proximal, on the distal side of the valve. Be aware if you're playing with these micro scissors, if you open it too wide, it's very easy to lacerate the wall of the cystic duct. Sometimes the ducts are very small. Usually a more distal dissection will find a larger diameter duct. A glide wire can be used. If that isn't the case, performing a cholecystogram is usually a safer option. That's, I should say, the way the pediatric surgeons do that, because pediatric cystic ducts are so tiny that if they're going to do a cholangiogram, they'll usually insert a catheter into the gallbladder itself and from there light up the biliary tree. Stones and debris within the cystic duct, you really got to tease them out through the ductotomy with sweeping motion along the porta hepatis and clean out the cystic duct. You don't want to flush stones into the common bile duct that aren't already there. It's really key to get nice looking bile flowing into your ductotomy, out of the ductotomy into the abdominal cavity. Hopefully it doesn't make too much of a mess. Another trick you can do is to gently crush the cystic duct itself and any stones in there and milk it out of the otomy just by crushing the duct. So you're sweeping the common duct and crushing, milking the cystic duct. Another alternative, and another thing we did yesterday in that difficult case, is to divide the gallbladder itself midway or 1/3 up on the body, being careful to control the spillage with a sponge or a specimen bag in Morrison's pouch. And once the gallbladder itself is divided and contents removed, you could then look in the remaining cup and ideally see the takeoff of the cystic duct origin. And it's possible to insert a catheter catheter directly into the duct itself from within the gallbladder cup. Finally, I'd like to talk about some just routine difficulties on cholangiogram interpretation. The first and the most common error of this type is to interpret the lower biliary tree, because we're excited about that. We're looking for stones, that's a big reason why we're doing these cholangiograms. And we say the study is normal without having visualized the hepatic ducts. And this can occur if the common bile duct has been instrumented or a clip is across the hepatic ducts. So it's important to take any erroneously clips out, to pull your catheter back, place the patient in Trendelenburg to help have contrast flow cranially. Alternatively, you can also give intravenous morphine or Demerol, which tightens up the sphincter of Oddi in an effort to demonstrate cranial flow. Lastly, you could always take a blunt grasper and squish the common duct, occlude it, almost like emergencies, so that any contrast you inject will be forced to go cranially, and then take more x-rays to prove that everything looks great. Alternatively, you'll shoot a cholangiogram, everything looks good, except contrast isn't going into the duodenum. And that should tell you that you probably have a common duct stone at the sphincter. The first step, of course, is to inject 1 milligram of glucagon, which promotes the relaxation of the smooth muscle of the sphincter of Oddi. You're going to wait 3 to 5 minutes and attempt to do the cholangiogram again. You can repeat that step a second time with a 2nd milligram of glucagon. Sometimes sometimes you just need a little extra hydrostatic force to pop that stone through. So make sure your tubing isn't kinked, either outside the body or in the cystic duct. And a nice trick is to exchange your big 30 ml syringes with a 10 ml syringe, which allows you to deliver greater hydrostatic force, and maybe you can pop that stone through. If not, then you need to think about ways to get that stone out, whether a laparoscopic common duct exploration is appropriate for that patient based on factors, duct size and stuff we're not getting into, or you can send the patient for ERCP after your surgery, or if the stones are small, even though you should be able to get them out, if they're small, you might consider hoping they'll pass spontaneously, but a patient will need pretty close follow-up post-operatively. Lastly, and my last slide is this. If you do enough cholangiography, you're going to get bubbled by your tech. Tech's going to swear there are no bubbles, but there are going to be bubbles in the tree that got past you. So how do you differentiate bubbles on your cholangiogram versus stones? Well, bubbles usually are perfect little spheres. Bubbles also tend to move more dynamically as you flush or even aspirate a little bit. They tend to move up and down with that column pretty freely in a way that stones don't. Another trick is to place the patient in reverse Trendelenburg, head up, which all of a sudden the bubbles will float towards the head, which a stone wouldn't do. But clearly, the best thing to do is to avoid getting bubbles in your system in the first place. At this point, I'd like to hand the talk back over to Dr. Vazquez so he can introduce our next speaker of the evening.
Well, Matt, thank you so much. That was a really thorough discussion, sir.
Very cool.
A very thorough discussion. I wanted to add one thing that I know that you didn't directly say it, but if you don't do a lot of them, you have to be able to outread a radiologist. You can't, if you can't read the cholangiogram better than a radiologist, you probably shouldn't do them, because you have to make a decision based on your reading. Because if they're going to second guess you and they're going to prove you wrong, you don't want that.
Well, in this day and age with the C-arm, exactly, C-arm becomes a surgeon study to interpret. It's not a radiologist study to interpret anymore. It's for you to learn how to do and interpret. Absolutely.
Oh, but you don't. But of course, they always do a reading later on.
Well, for 72 hours later, you can find out.
Exactly. 72 hours later, they do a reading, and you want to make sure that you've outread them. You know. At any rate, absolutely great talk. And we're going to go ahead and go on to Sal. Sal's going to speak a bit about the C-arm itself and some radiation safety, and maybe remind everybody why and where the X-rays actually come from, where the tube is, and how to collimate and do things like that. So I'm having a great time. This is a great review. I hope our audience is enjoying this as much as I am. Sal, take off.
Thank you so much, Dr. Vazquez. And that was a phenomenal talk. Excellent. And thanks again for SAGES for the invite to speak. So I'm going to be talking a little bit about C-arm cart use and safety. And obviously we're going to, there's individuals that are located in our hospital that are really, our X-ray techs are fantastic. At our hospital in particular, I feel like we have a really solid working relationship with them. They're very well trained. They're very protective in terms of what they do. So I think that's good. They take pride in what they do as well. But that being said, there still has to be a portion in terms of what we do, and in terms of being responsible for the equipment that comes in the room, responsible for doing these procedures. And there's always a little bit of variability in terms of who's in the room with you and who's doing what. So I think there's obviously an importance to understanding the basics of how to use some of this instrumentation, and really just kind of understanding the basics of it overall. These are just some of my own disclosures. Nothing really pertinent to any of these talks, this talk in particular. So things matter. I really like to kind of understand X-ray and C-arm history. I think it does just kind of adds a little bit of a interesting flavor and kind of overall view in terms of what you're doing, because you really want to understand where you're coming from if you're going to if you really want to know where you're going. And because kind of the history is always fun too to understand. So X-ray overall was really discovered in 1895 by Conrad Rinch and William back in Germany. And for the most part, he was just playing some with cathodes, and he noticed that at times when he would provide energy to the cathode, he would get excitation. These fluorescent materials next to the cathode would get really excited and start to glow. And then he's like, okay, well, what does that mean? Then he wrapped the cathode around like black dark paper. And again, the fluorescent materials would get excited and time it would be energized. So he's saying, okay, something else interesting is going on here. And then he really kind of discovered that there's probably some other type of particles, or, which would later be coined X-ray beams coming out. And he started playing around with the cathode, and he noted that the X-rays would penetrate flesh, but not bone or metal objects. And the first X-ray that's really been documented was taken of his wife's hand, Bertha, and that was again 1895. And there's a picture of it, of that X-ray, and you can clearly see some of the cloudy, bony structures. You can even see one of her rings that she was still wearing at the time of the X-ray. So overall, really kind of interesting. And then over time, the X-ray machine was developed, but it became very stagnant, and really a revolution in terms of what we could do in the hospital came from a simple concept where in 1955, we placed the first X-ray machine based on a mobile unit, and that's where the C-arm came from. Obviously, the C-arm really just kind of holds a name from the fact that it's shaped like a giant C. And again, it really, kind of revolutionized what we could do in the operating room, because now X-rays became mobile. You're able to move them from one room to another. You were able to move the devices to the patient instead of having to bring the patient to a stagnant X-ray machine. And the other interesting aspect of this is that the X-ray, this machine can now be moved in various directions, right? Because you have the C-arm that could pivot back and forth. And that was really kind of a unique part of the design of this product as well. And then in 1957, an image intensifier was then linked to the monitor and television screen. So, and we'll go over this in a little bit more detail, but what's kind of interesting, and I think most people don't understand or don't know, is that the X-ray beams, the X-ray source is actually at the bottom of the C-arm. It actually goes from the ground to the ceiling. So it goes in that direction. And the beams will then get captured by the intensifier, which is located above the patient. And what was unique about this is that they took the image that was generated from an intensifier, they linked it to the monitor, and then that monitor obviously got linked to the television screen. So now you could take X-rays in real time. You didn't have to take a film. You didn't have to go sit in a dark room for 15 to 20 minutes and wait for this thing to materialize. You can pretty almost instantaneously get an image. And most importantly, if the image wasn't good or accurate, you could simply repeat it. So just kind of understanding the basic anatomy of a C-arm, right? And the C-arm is, again, it's a machine, obviously, but it's a little bit bulky. So just a general rule of thumb is understand where you're using this in space. And what does that mean? Understand the size of your room. So sometimes, we do, and we'll go over this in a tiny bit of detail a little bit at the end of the talk briefly. But sometimes I do intra-op cholangiograms while doing a robotic chole. We do cholecystoscopy robotically as well. And when you have a robot in the room, when you have dual consoles, then you got to bring all this additional equipment. You want to understand, how am I going to get this in? So you understand what the parts of the C-arm are made up of. And for the most part, you're going to have that collimator or the X-ray tube. You have the intensifier, which is above. And then obviously you have the C-arm, which is going to move horizontally or vertically as well in regards to relation to the patient. And then the control panel. And these are really the main important parts that, any surgeon, anybody, operating this machine really needs to at least know those parts pretty well. And then obviously on the dual monitor, the display, you have different abilities to save images, change images on the display monitor as well. So understanding the C-arm movements. So the C-arm can move in two different main directions. The X-ray that I mentioned earlier, the source is coming from the bottom, so it's going bottom to top. The intensifier, as I mentioned, is located at the top that captures all the X-rays. In order to get the best picture and to reduce radiation scatter, you really want to have the intensifier as close to the patient as possible. And that's the key. It's not the X-ray beam itself, but it's the intensifier to give you the best pictures. And the C-arm itself can really rotate in two different degrees. It can rotate, basically, if you're looking at a head-to-toe axis, the C-arm can rotate right anterior oblique to 90 degrees, or it can rotate left anterior oblique to 90 degrees, right? So when you move the C-arm in, depending on what pictures you want to get, it's important to know that how you can rotate the C-arm back and forth overall, if you're looking from a head-to-toe axis. And that's important, right? Because if you're doing, let's say you're doing a cholangiogram and you have graspers in the patient and you take an X-ray and one of the graspers is going right over the cystic duct or the common bile duct, and you can't see if there's impacted stones, etc., you can simply just rotate the C-arm and get a different angle and really then visualize the anatomy. So it's important to understand that so you don't have to manipulate the patient's bed or move the patients around. So that's one axis that you have for the patient. Another axis is going to be in the almost horizontal to the head-to-toe axis in the craniocaudal manner. So same way, you can move 90 degrees craniocaudal. Again, really important to understand these two different types of axes that you can rotate the C-arm across, because same situation, if you're taking an image and your instrumentation is in the way, or you can't see an image for whatever reason, maybe it's lined up with the spine, etc., you can simply move the C-arm to get a better visualization. So important concepts to know and understand. In regards to the control panel, it's important to understand some basic concepts here. And again, I'm not going to go into too much detail here, but there's some points that I'm going to point out that I think anybody who needs to understand basic C-arm use needs to understand. Orientation, this is where you can flip the screens from left to right. So that's important, because if you take a still image and the screen is kind of opposite, you can simply hit the different R's and it'll literally just flip the picture from left to right. So simply kind of corrects your orientation. Saving the image, so they kind of looks like a stack of coins. That was a term that was often used in our fellowship. just the left lower part of the control panel. It looks like a stack of coins, and that's basically to save your images. So if you need to kind of compare image before and after, obviously if you're doing a cholangiogram and there's a stone in the common bile duct, you really want to save that image, and then you want to do a completion cholangiogram and show that it's clear after. So important to save your work. And then also, the reality is if you're in practices where you are reading your own images on C-arms, saving that images, putting it to the PAC system also obviously gives you ability to also read and bill for those images as well. Collimation is a technique where you can actually limit the amount of radiation that's being viewed. So what does that mean? Let's say we took a picture, we take a still shot of the biliary tract, but we're also getting additional organs, such as we're getting the majority of the liver, we're getting the stomach, etc. In order to limit or reduce the exposure to radiation, you can use the collimation where you can shrink the amount of radiation only to the biliary tract, for instance. And what that does is it limits the amount of radiation that the patient's exposed to. Okay. Now, pulse is basically one pulse of X-ray and then it stops. So when you're doing a cholangiogram, you can run the X-ray continuously, meaning that's continuously taking X-ray photos or pictures. It's just a constant. Whereas when you do a pulse allows you to simply, when you take a shot, it takes one main shot and then it stops. It's a safety mechanism. And what it does is it allows you to limit the amount of exposure to the patient. And then finally, fluoro time, and this is given in units of seconds. And the fluoro time is exactly what that is, right? It's accumulation of all the fluoroscopy that you're being used during a case. Typically, when you're doing a cholangiogram or you're doing a case, a biliary case, honestly, you should probably not get more than like 2 to 3 minutes of exposure to radiation. Anything beyond that is probably a little bit much. So in your own mind, when you're doing these cases, kind of keep that as a specific limit. If you keep it under a minute, that's fantastic. Anything beyond 2 to 3 minutes, probably a little too much. And maybe even it's a good rule of thumb, because if you're constantly going over multiple minutes, if every case you're using 5 minutes of fluoro, that's a lot. You should probably reevaluate kind of your methodology, how to limit the exposure to the patient, to you as the physician, and then also for the staff in the room. Some basic X-rays, and again, I'm putting this up. I'm going to put this up for reference. I won't read through all of it, but I think it's really good to just kind of understand the basics of the intensifier. So basically, the X-ray comes in. It's going to go through the patient. It's going to hit basically a fluorescent input screen. And what it does is they use that visual light and it actually just excites a bunch of electrons. And then what that does is those electrons are then refocused and it goes to an anode, and then it hits this output, phosphorus-based output producer that basically converts it to, again, visible light at the end. And then at the end of the intensifier, that picture is then basically run through to a TV screen nowadays. And that's basically the basics of how this works. So it's all up here to kind of, if you need it for your own review, but I think it's good to understand just the basics of it, but I won't spend too much time on this. All right, so C-arm and safety, which is really kind of the main focus of this lecture. And I think for the most part, as the operative surgeon, you should be the captain of the ship. You should really be a really strong champion of safety in the operating room. And that also goes, anytime you're using any type of radiation, you got to really be mindful of, again, as I mentioned before, the patient, yourself, and the staff, okay? First and foremost, what does that mean? For yourself, and then for all the individuals in the room, you want to make sure they're all wearing safety, safety devices or personal protective equipment. That includes the basics of lead apron, thyroid shields, and then also in many instances, also radiation monitoring devices. And then most of us should also have a personal design radiation that goes onto your clothing or your lead apron that you should check at least every couple months to a year and make sure you're not getting overdosed with radiation. So basic concepts. So anytime I fire, anytime I use a C-arm, I'm about to take a fire, I will ask, is everyone properly protected in the operating room? And I want to wait to make sure I get that confirmation that everyone is safe and it's appropriate to move forward. The second thing is we should all practice something called ALAR, which is as low as reasonably achievable principles. So what does that mean? That basically means that it is something where you need to balance the risks with the benefits of what you're doing in regards to radiation. And again, this was a concept that was put out to the International Commission on Radiology on Radiographic Protection. And again, it was a concept in which everyone in the room should go above and beyond to ensure that we're getting the limited amount of radiation. And for the most for most aspects of this, it's really, you need to make sure that everyone in the room has proper equipment. All the personnel, including the operative surgeon, has to also be well educated in terms of how to use equipment, how to limit the amount of exposure. And again, it's kind of these things that we mentioned before. The intensifier, which is the top of the C-arm, that should be as close to the patient. That allows you to get really nice, clear pictures. It ensures that you're not taking multiple pictures as well. Try to do other things in terms of limit the X-ray, right? Don't do full active runs every time. Maybe take some still shots. Take 1 or 2 still shots to ensure that you're in the proper location, and then you can kind of do 1 or 2 runs and then limit it as much as possible. Have good defined goals in terms of what you're trying to achieve when you're using the C-arm in the operating room. So again, really good to practice ALARA principles all the time, anytime you're being exposed or using radiation. In terms of looking at other options for ALARA, pulse fluoroscopy, as I mentioned before, having that pulse option is really important, because it'll stop the X-ray machine every so often, every time you use it, instead of having a continuous exposure. The collimation, as I mentioned before, it allows the operator to focus the radiation on a point of interest. Basically, if you can imagine, there's essentially lead panels or plates that are going to come into center. And what it does is that when you fire the X-ray, it's going to be simply viewed upon that very specific structure. So it restricts the amount of radiation to only the objects that you want to focus on. So if you only want to focus on the biliary tree, you can simply close the collimation beams and only focus on the biliary tree. And then, as I mentioned earlier, again, the image intensifier, be as near as possible to the patient. It's going to get you really clear pictures, and it's going to obviously limit the amount of radiation scatter. So other thing too is understand, how do we talk about, detrimental effects of radiation? Because we all know radiation will eventually damage cells over time, which can obviously lead to oncologic procedures. Sievert is basically an effective dose, right? So what does that mean? It's a measure of all the overall detriment or health effects of the radiation itself on human tissues. And we'll go over the equation briefly here. And it's not, what I want you to just understand is that the basics of the dosages. So a lumbar radiograph gives you basically 1.5 millisieverts, whereas a CT lumbar gives you 15. So you can understand the differences in dosages there in terms of a CT scan versus one basic flat plate X-ray. And this is the equation. Again, just put it up here for your reference. But just kind of understand the basics of it. So when you fire an X-ray, there's going to be a multiplier, which is basically a weighting factor. And every individual organ has a different type of a weighing factor to it. But then also, more importantly, it also has a tissue weighting factor for each individual tissue or organ. So what does that mean? That means that every organ in your body, like the brain versus the stomach, has a tissue weighting factor. Basically, it means that the way that it gets altered or affected by radiation it varies between organ and organ. And that makes sense, right? You would think that the brain, for instance, may be more susceptible to radiation than, let's say, a femur or the stomach or the liver. And then what happens is you sum up these various different organs and how much they got exposed to how much radiation, and it gives you that sievert dosage. So that's basically the concept behind that. And again, it just makes perfect sense that it depends on how much radiation that you're being exposed to, which organs were exposed, and then then we take the sum of that, and that's what gives us our specific amounts. So the U.S. National Council on Radiation Protection and Measurements put out some guidelines and recommendations, and what they stated was, for the ICRP, they really said that you should dose limit. If you're working as a surgeon, for instance, your whole body effective dose should be about 20 millisieverts per year, and that could be averaged over about 5 years or so. Again, it's also, the NCRP has a higher recommendation, and that's about 50 per year. A little bit of a big discrepancy there, but it's still these general guidelines that keep in mind if you're going to a field with a lot of significant radiation exposure, such as interventional radiology, vascular surgery, and obviously even general surgery as well. No dose is advisable at any time during pregnancy as well. So beyond 5 millisieverts as well. So it's something to keep in mind. And again, if we want to look at how does this affect the human being, most studies have shown that 1 sievert overall of exposure imparts a 60% increase in developing a solid malignancy. So that's 1 sievert. And again, these dosages are in milli. So just to kind of keep that in the back of your mind. So really important to understand the dosages, the concepts of what does exposure mean for a physician and yourself. And again, because don't forget, this could be a cumulative exposure over, 20, 30, even up to 40 years. And obviously continued exposure is going to accumulate and really could cause some, injury over time. So important to protect yourself, important to protect your staff in the room as well. So a couple other instances of this. And again, Matt went over this fantastic. I don't want to take too much time on this for the most part, but a couple of things, as I mentioned before, keep the intensifier close to the body, prepare in terms of what you're doing. Like I always you want to maybe tuck the right arm. You want to make sure the bed is properly placed in the proper position so you're not struggling to get your picture. All of this stuff is in terms of preparing the use of the C-arm during the case. And again, understand what you're looking at. Again, Matt went over this really great. I'm going to spend too much time, but you don't want to spend too much time taking multiple pictures. You want to have an idea of what you're looking for, understand what's normal and abnormal during a cholangiogram. And really the C-arm use, proper usage of the C-arm can really help a lot in terms of understanding the pathology, where the stones, how many stones there are, how it affects outcome. And then obviously, how can you tackle this? If it's smaller stones, maybe you could do transcystic cholecystectomy. Larger stones, you have to go through the common bile duct. Some stones are impacted. Maybe you have to just do a cholecystectomy and send them for an ERCP. So understanding the use of the C-arm and what pictures you can develop is obviously really important to what you're trying to achieve in the operating room. And then finally, just in one last concept for the last few minutes here is, also robot cholecystectomy as the use of robotics, especially in general surgery, becomes more prevalent. As we're doing more and more robotic cholecystectomies, we want to make sure that we're still providing good care to our patients. So what does that mean? That means that if you need to do a cholangiogram, you should still be able to do it, even if you're doing a robotic cholecystectomy. If you need to do a choledocoscopy and you're in the middle of a robotic case, you don't want to not treat the patient the way you would normally if you're doing a robotic case versus a laparoscopy case. So we've done quite a few of robotic choledocoscopy, including cholangiograms, and we put out this paper, a little bit of how-to manual. I think it's really important to understand, how to utilize C-arm placement during robotic cases. And again, these are our port placements. There's nothing out of the ordinary here, nothing special that we're doing during our port placement. We do standard robotic ports for cholecystectomy. My room setup is really typical of the C-arm is going to come in from the patient's right. We use a left dock for the robot. And then I usually have a cholecystectomy cart, usually at the patient's right side. And I have an auxiliary monitor on the patient's left side so I can visualize what I'm doing from a cholecystectomy standpoint. So what we typically do is we obviously get our critical view of safety. And then the way that we position the arms are basically arms 1 and 2 are going to go down to the patient's right side or right hip, and they're going to be swung out to the left. Arms 3 and 4, patient's left hip swung out to the left. And what that does is it simply creates an open space for your C-arm to come in, and you're going to get your pictures and do your cholangiogram. So the way that we set up this bed, and again, it's all about preparation, is obviously the patient's going to be a little bit head up. We're going to position our C-arm, and the C-arm is going to slowly come in, and it's going to go right over the robotic arms. And then as you swung those robotic arms outward, again, you're going to create a little window that you can simply get a nice, perform a typical cholangiogram. And this allows us to perform, again, we could do a cholecystectomy. We don't have to undock. We can still perform our imaging. So we can really treat the patient as best as I would if I was doing a laparoscopic case as well. And again, this is about preparation. This is about having conversations. When our tech first came in, they were obviously a little bit nervous because, it was one of the first cases that they had done robotically. But again, I was comfortable using the C-arm. We had a really good conversation in terms of what our goal was, how we're going to bring the CRM, how we're going to get this completed. And then at that point, once we did our cholangiogram, we moved forward and we just completed our choledocoscopy as well as at the bedside. Again, never on dock. And again, this is all about preparation and understanding how to use these devices. Because again, when the individual came in the room, radiation tech, they were obviously a little nervous about how they were going to get this in here, but I was able to help them walk through it because I felt comfortable, using the C-arm myself. So this is just a basic case. I won't go into too much of this because we're going to cover this a little bit later during the lecture. But again, once we did our cholangiogram, we completed this. We did choledocoscopy, robotically as well, and then we kind of just, did our completion cholangiogram and moved on. So In basic conclusion, you really want to understand how the C-arm functions, as we kind of went over. Preparation is key. I think like anything else in surgery, right? You want to prepare for success. So if you're doing if you're using the C-arm in a complicated situation, such as during a robotic cholecystectomy, have a talk with whoever the tech is in the room, help them out, understand how to swing the C-arm, backwards, forwards. Obviously practice ALARA as well, limit as much of the radiation exposure as possible. And again, that includes having a defined plan, what pictures you want to take, what views you need to get to accomplish what you need to accomplish. Be a proponent of personal protective equipment, lead by example. So make sure you are wearing your thyroid shield, make sure you're wearing your lead, make sure you're wearing your lead glasses as well. And you're the captain of the ship, so you want to make sure that all the staff members in the room are wearing all the protective equipment as well. The goal of this is to, again, accomplish take good care of patients, but limit the radiation. Radiation, don't forget, is cumulative, right? So if you're doing this, a couple times a week over a couple of years, it's a lot of exposure. So understand what your limits are for annual exposure to radiation. And again, overall, just prepare for success. So thanks for your time, and I'll hand it back over to Dr. Vazquez as well. Thanks, everybody.
Wow. That's nice job. Lots of information, very useful information.
Thank you. Thank you.
I really appreciate that. And emphasizing the ALARA principle is critically important. Knowing where the radiation is coming from is handy because of the occasional time when you're stuck having to use a C-arm during pregnancy. So the patient, putting lead on top of the patient won't do anything. Okay.
That's a fantastic point. That is true. So I think you're right. If there's portions of the body that you really need to protect, and in actuality, the lead has to go underneath the patient.
Right.
That's really that, preparing and understanding how the equipment that we are all using in the room, how it works, how it functions, is just absolutely key to keeping the patient, yourself, and everyone in the room safe.
Right. Fantastic. Excellent talk. Okay, the bar is pretty high, Adnan.
Sal, that was incredible. Just curious, how did you end up getting to know so much about the physics? And I mean, I thought I knew, C-arms until you started talking, but that's impressive.
Yeah, it's a passion of mine. I love C-arms.
That's incredible. Good for you. That's amazing. That was a very, very educational.
Thanks.
Hopefully we'll get the attendees to start writing some questions, and thank you so much, Dr. Vazquez, for the invite, and I'm honored to speak on ultrasound. So a little bit of a changing gears here. Just for clarity, are you seeing the right screen, or which screen are you seeing?
We're seeing both screens actually. So the screen and the
oh, I see. Let me stop that.
yeah, you need to change the view.
Okay, let me just stop sharing, and I'll share again.
So Adnan, I went out and became certified in ultrasonography as well.
That's fantastic.
As a technician and as an interpreter.
That's awesome. So do you see the correct screen now?
Yeah, now we're seeing it. So I mean, yeah, okay. I'm like Sal. I love physics.
That's amazing. Well, as Dr. Vazquez said, my name is Adnan Alseidi. I'm one of the HPB surgeons here in San Francisco, and it's an honor to speak with this group. And I'm looking forward to a bunch of questions. And I'll just disclose that, I don't know, maybe it's my surgeon mentality, but I thought this was a little bit of a competition or a debate. So I apologize if there's a little bit of a debate, a little bit of a comparison thing in my slide set. It's probably unnecessary, but I'll be speaking about ultrasound. So I do want to take a moment to acknowledge that Dr. Westcott and Dr. Bowers and I, about a year and a half ago, decided that this is a tool that is necessary for really the laparoscopic and robotic surgeon, general surgeon. And so we kind of started working with one of the ultrasound companies, GE and VK, from SAGES, to basically create these modules. So some of these videos are theirs, and I appreciate their they're, we're sharing all of these for the public, so certainly nothing to disclose here except that this work is a combination of our 3 works with BK and GE, but it's all public and accessible. So I want to just start by kind of saying, think about if you were to be asked, do you want a tool that's super easy to set up, that's actually billable, that's easy to document, no radiation. You can repeat it as many times as you want without really changing your setup at all. You don't even have to have anybody else in the room. And you can use it whether it's open, laparoscopic, or robotic, the same instruments. There's zero cost in using it. There's obviously a cost in the capital to buy the equipment. However, I would say that the vast majority of hospitals, because of radiology moving very strongly laparoscopically and robotically, probably have already the ability to perform laparoscopic and robotic ultrasound. So I would encourage you to ask your robotic colleagues, but I bet you already have this equipment. But besides the equipment, then you don't really need anything. This tool also allows you to see amazing anatomy. It's really the best tool out there for stones by far. It's the best tool for masses, and I'll show you why. It's also helpful for more than just identifying the anatomy in stones, but it's also helpful in really bad, ugly gallbladders to do a bailout procedure with really very little risk. Think of we used to do a lot of subclavians and IJs without ultrasound. Now it's pretty much standard of care. Not that we can't do it without, but why would you when you can see exactly where your needle is? Same thing for doing subtotals and drainage and even common bile duct exploration. You can do certainly cholangiogram is wonderful, as you saw what Matt and Sal showed. However, what I like to do is I basically once I've cleared the common bile duct, I just use the ultrasound, and that way I don't have to reset up anything and just use it to make sure that I don't have anything left behind. It's also transferable to other procedures outside biliary, and I'll show you some of that as well. So obviously, all of this I'm talking about ultrasound, and really, I think the general surgeon is comfortable with ultrasound open, but not as comfortable laparoscopically and robotically. So I'm an HPV surgeon, and so it's hard for me to think of a case that I'm not using this. But I would tell you the principles are the same. The comfort comes very quickly since you already know about ultrasound, and I would encourage you to think about it. So we'll talk a little bit about why, we'll talk about how, we'll talk about a little bit of workflow and a little bit of examples, and then I'll give you a couple slides, a couple sites to think about, to look at, which will really take you step by step through it. And I would really encourage you to just try it. Just try it. I mean, I know I started teaching the hands-on course at SAGES for laparoscopic common bile duct exploration, and the people that teach it are superstars in laparoscopic common bile duct exploration using fluoro and using colodocoscope. And a couple of them, they saw the talk about ultrasound and they decided to try it, and now they incorporated it into their armamentarium, and they use ultrasound, for a bad gallbladder to know exactly what's inside it. Is there a mass or not? Things like that. So it's just really incredibly helpful, and it's very, very easy to get to know how to use. So let's talk a little bit about a comparison, just not to say that one is better than the other, but to say, when do you use one over the other? Because we're lucky now that we have so many different ways to image the bile duct. That's why we're here to talk about this. And think about it in terms of risk. Think about it in terms of how immediate you can use it. How easy is it to repeat? How good is it for stones, for tumors, for vessels, to demystify the anatomy in bad gallbladders? But also, how can you see beyond the naked eye? And you compare that to ICG and to IOC, and you see that the ultrasound is at least non-inferior, if not superior, in almost all of these areas. And that's why, for me, the go-to thing is ultrasound. Now, do I use ICG? 100%. Of course I do. Do I use IOC? Absolutely. However, I use it when ultrasound is not able to help me, and that makes me use those less. And that's not bad or good. It's just what I've gotten comfortable with. And I could tell you that ultrasound, when it comes to, like, I just did a sleeve gastrectomy on a gist, and it was very difficult to find. It's a laparoscopic case. Like, it's very difficult to know where this gist is. It wasn't tattooed, so I just have the the anesthesiologist put about 20 cc's of saline into the stomach, and that's a perfect medium, and you can see exactly where it is, and then you just do your procedure. It's just, I've kind of come to use it in almost every case. So this is kind of just a comparison to get you thinking about it. Now, let's talk about how to do it, because a lot of times people, feel a little uncomfortable with kind of taking that leap and thinking that everything is going to be very challenging to do. And for that reason, I encourage you to look at this free resource that again, Carl and Ryan and myself kind of help pull together, and I think it's really well done. And I want to thank Kevin from BK and GE that has helped us actually put the technique on the technology behind this, which is fantastic. You'll see that there's multiple modules. There's a modules on intraoperative ultrasound for laparoscopic cholecystectomy. You'll see things for common bile duct exploration, but you'll see kind of modules to basically talk about just simple ultrasound to understand the anatomy. And I would encourage you to start using it even on just normal procedures until you get comfortable, and I'm sure it won't take that long. Here are some videos just to show you how well the ultrasound has become, because a lot of times some people think it's really kind of a big deal to kind of get used to this. But here you can start seeing the common bile duct, and these are actually ultrasounds that are done without any kind of fluid in the abdomen. You can see sludge very easily. I'll show you here's a longitudinal cut that actually shows you a Morson's pouch, shows you the kidney, the liver, the interface. These are obviously not very ugly gallbladders, but I'm just using them as a medium to just show you how well you can see the wall, you can see the sludge, and the mass is much easier. And again, remember that ultrasound has become so good that our GI colleagues and people like Sal, who are trained endoscopically, use it to actually differentiate tumors that are T1 from T2 from T3. So literally we're talking about, layers within the abdominal wall that you can differentiate. Cardiology uses it to diagnose nodules of endocarditis of 1 and 2 millimeter nodules. So again, this is not, the ultrasound of the olden days where it was really not as good. But also remember, you're going to see abnormal anatomy in the liver all the time and in the abdomen, and you could put all ultrasound on it and you can actually know exactly what it is, and it just gives you that comfort to know what it is. So here's a quick video that I'm going to show you. Dr. Vazquez, let me know if you don't hear the sound.
I don't hear the sound.
Okay, let me actually stop and reshare. I don't think I shared the sound. You just reshare again.
Yeah. Click those 2 check marks.
Yeah, I think I forgot to do that. 1 second. Sound optimize. Got it. Okay.
And video too. You want to click video.
Mm-hmm. I did
Okay.
that now. Okay, I think, let's see if this plays.
Getting started.
Once I optimize my probe, I like to scan my
Okay.
gallbladder to make sure
So
there's no
this video,
masses
for
or anything
example,
like that.
again, it's
And you can see
free
here what I'm doing
online.
is I'm scanning the
You should
gallbladder
be hearing my
through the liver as an
narration,
acoustic
and it has
window. And when I do
the
that, I'm
ultrasound and
basically
has
looking
the
at the liver and also
laparoscopy,
gallbladder,
and it basically
and
just takes you
also
step by
at
step on
Tract
just
and
how to
kidney,
kind of
all of them. So
optimize
here you
it.
can see the liver really
Um,
closely, and I can see the
they're
right and
really,
left
and
liver,
it's kind of
or segment 4 and 5, that is,
goes
and then you can
over
see the
really
gallbladder.
where
And
people
as I
make the most common mistakes, like, so for example, what's left and what's right, and this will go over things like that, but also will go over things like, okay, how do you know what's left and right, and then how do you optimize the depth? Again, this will go
with a
over all of
millimeter
that details, but I'll show you one more thing,
block
again, a
of
trick
the
that
probe up here, the screen here will move 3/4 centimeters. So keep that in mind, that everything is a little exaggerated. Here you see the gallbladder again, and I'm doing really just a sagittal cut of the gallbladder. Actually, it's more like an axial cut of the gallbladder, but the gallbladder in this case is a little bit sideways. And you can see that there is a finding here in the gallbladder. So I'm going to go very slow movements around that finding. Actually, I'm still scanning the gallbladder itself, but when I see that finding, Notice how little the probe is moving, and I'm basically seeing what is it. And you can see that there's classic characteristics of that, finding that it's a stone. And you can see there's shadowing, and it's dependent, meaning that it's basically at the bottom of the gallbladder, so it's responded to gravity.
So I'm going to fast forward a
I'm
little bit. And
basically,
again, many of you may already know all of this, but I just
no
wanted to make
surprise
sure
that
that you guys get
literally 2-3
the help you
millimeters
need. But it
of
shows you
mercury
how
of
to use the
pressure
liver as
go
a
away.
medium to
This is
see
not a problem
the portal
because, again, I'm
anatomy.
not doing
But
any
also, I'm going to show
dissection.
you a technique here called the standoff
And
technique. So
actually
I'm going to fast
decrease that
forward.
sensitivity so I can actually avoid that extra noise that's happening right now. But so now you'll see what I'm doing, what's called the standoff technique. I wasn't able to get the bile duct really nicely. So you see, I'm going to put some saline.
And just for clarity, this, a lot of times people struggle with laparoscopy and robotics in the sense that it's hard to do a common bile duct exposure when there's air, because the common bile duct is small, and sometimes you see air and it makes a lot of noise on ultrasound. So the standoff technique basically fixes that problem, but also remember using the liver as a medium to do ultrasound through it. But you can look at this.
So now you'll see what I'm doing, what's called the standoff technique. I wasn't able to get the bile duct really nicely. So you see, I'm going to put some saline in here. And you don't need a lot of saline, just a little bit of saline, but that goes a long way to allow you to basically remove, not necessarily care about significant contact. So now look at the difference. The difference is
so when you put that water now, or that saline, again, it's just really like not even 10 cc's. Now, all those air bubbles and all that air around the porta goes away, and you can actually easily see even a millimeter or two bile ducts and arteries very nicely.
Huge in what you can see is now I'm going to scan through the bile duct, through the liver, but even through the porta, and all those small areas where there was air and it's making my visualization poor now go away, because now I just literally can just put my probe on the water, and I can.
Now, I want to just show you here. You see, this is the duodenum, and you could see the duodenum or the pylorus. You could literally see the layers of the pylorus. Now, of course, I have it down to 8 centimeters. If I really wanted to see this, I can just lower my depth to 2-3 centimeters, and you'll see it magnified really nicely. I just wanted to keep this window big so everybody can see. But again, this is the idea here, is that there's a lot of resources for you all to be comfortable with ultrasound, and I encourage you to look at that. And as I said, this is a free resource, but also if you look here, I'm just going to go back real quickly just to show you the link and the I think this is all recorded anyway, but there's a link and a QR code here as well. Where is it? Here. Okay. So going forward, I just want to kind of point out that the ultrasound is not really just about looking at the gallbladder and common bile ducts, but it's really, for me, incredibly essential when the gallbladder gets nasty. And so think about it when we have the zone of danger. And this is, when the cystohepatic window is fused, and Matt talked about this, this becomes a really hostile area that basically you can get into a lot of trouble. And this is a picture that Matt also showed, where basically your cystohepatic window here basically gets fused. In this area, as you know from the guidelines that Dr. Brunt led and published, and SAGES co-sponsored, it's not recommended to do a total cholecystectomy. In other words, a proceeding with trying to dissect the cystohepatic window to get a critical view is dangerous, but also doing a top-down is dangerous, because when you're doing a top-down in this area, in fact, you're very high risk, not just for a bile duct injury, but for a vascular biliary injury, meaning injuring the right hepatic artery and the bile duct. So in this situation, a total cholecystectomy is contraindicated. In these situations, the recommendation is to get into the gallbladder and to do a subtotal cholecystectomy. And this surgery still makes a lot of people nervous, and it's understandably so. It's not something we do every day. But you have an ultrasound that you can look inside. You can actually see. You can make sure it's not a mass. If it's a mass, you leave it alone. You send that to a surgical oncologist. But if it's not a mass, then you go into the gallbladder. But also you go into the gallbladder knowing where the gallbladder ends, where gallbladder starts, and you know where the stones are. And stones are incredibly easy to see with ultrasound, as I showed you before. And it does not take any kind of injection or anything like that. You just put the ultrasound probe on the liver and you see everything everything right away. And when you do that, you're able then to proceed and do a subtotal cholecystectomy in much safer fashion. The beautiful thing about the ultrasound is that it actually can allow you to relieve your anxiety of what we call triggers for positive safety. Now, what are triggers? These are all triggers, and this is triggers that have been identified through multiple international studies, one from Taiwan, one from Japan, multiple in the United States, that when you have any of these things, as a surgeon that's taking out gallbladders, you should stop. That doesn't mean you should stop and not complete the surgery. No, it means you should stop and make sure that you do something else to basically clarify your anatomy, because these mean that these will increase the risk of a bile duct injury. So we kind of look at it this way: if you have a laparoscopic cholecystectomy and you have a pause for safety, if there is there a pause for safety? No, then you proceed and you complete your cholecystectomy. Is there a pause for safety? Yes. Then you stop and you do something. What is that something? IOC. In my to getting a second opinion, all of these are viable. For me, I do intraoperative ultrasound, and it demystifies all of this. It tells me if there's a meristy. It tells me if there's a colodocal cyst. It tells me if there's a mass. Again, it's very easy, straightforward, risk-free, no radiation, and you can actually know exactly what you're dealing with. Once you get comfortable with ultrasound, you will see that you start using it for a lot of different things. I still take acute care surgery call, and just a few weeks ago, he had a horrible appendicitis, and I really couldn't tell if it was behind the cecum or if it was just disintegrated. And I just put some fluid and some saline in the right lower quadrant and just did an ultrasound, and I can see everything. And so it's a way for me to cheat and not have to guess, and I can see everything. And so I use it literally for stomach. I just did that like 2 hours ago. Appendix, kidney, pancreas, adrenal glands. I use it for adrenal glands all the time, because sometimes if you have somebody with a lot of retroperitoneal fat, you don't actually know where the adrenal, where the right, left renal vein to find the adrenal vein. And you could do it. You could find it by dissecting, but why? Like, it's 2024. Just use an ultrasound and know exactly where it is. Same thing for biopsies and ablation and targeting. Obviously, I use that as well. So, and of course, in addition to all the things we talked about, one thing to keep in mind is that it's billable as well. So obviously, you do need real-time image documentation if you're using this CP code. If you're not and if you're using this limited one, you don't need documentation. But either way, it's an adjunct that you could use, and it's free. And it's billable. So with that, I'll stop. Thank you so much, Dr. Vazquez, for the invite, and I look forward to the discussions, and I look forward to people putting in questions as well.
Well, I'm jealous. Nobody ever taught me that well on how to do an ultrasound in the biliary tract, and wonderful job. I think you probably have encouraged a lot of people to pick up the tool and get with the program. All right, we have one more expert coming here, Dana. Dana, tell them you want to introduce yourself, give a little bio, where you're working, what you're doing, and don't tell them that you'd never stop working, because that's the truth.
Thank you so much for having me. I'm so excited. Dana Telem at the University of Michigan, and I want to shout out Allison Morgan in the chat, who's the only one brave enough to tell me what PGY she is, and which and how many she's done. And I saw that she put in 3 cholangiograms as a PGY4, and I don't think that that's shocking at all. I think, those are the reasons that we're doing the webinars tonight. Is it is a little bit of a dying art form, and it's feast or famine. You either get into a situation where you're with always cholangiographers, or with, I loved when Matt Bloom said selective cholangiographers who select not to do it. And I think that's probably more true than not. And just to correct Adnan, because I can't control myself, IOC is also a billable code. So you do get 11.7 RVUs versus 10.7 10.72 RVUs for that. So now kind of going on, it's really great to see some close friends and colleagues up here. Do you see my presenter? Do you see presenter mode, or do you see the actual mode? Perfect. I'm here to talk about cholangiography. These are my disclosures. They don't impact anything I'm going to talk about today. And I think the really fun thing about cholangiography is similar to what Adnan said, is that it's just another tool in your toolbox that doesn't involve a ton of equipment, doesn't involve a lot of radiation. It's just something to think about. But like all things that we use, I think it's really important to know kind of the basis of what we're using, the safety profile of what we use, how it's administered, and the different things that you could do. So believe it or not, ICG has been FDA approved for literally for the last 50 years. This is not a new medication. This is not something that's novel or, really innovative. It's really been around for a really long time. And essentially what it is a lyophilized green powder, and that's just a fancy word to say that it's dehydrated. And what it does is it contains about 25 milligrams of indocyanine green that's mixed with 5% sodium iodine. And essentially it's dissolved in sterile IV for use. And what it essentially does is it binds to your plasma protein, of which albumin is the principal carrier. And then it's taken up from the plasma by the hepatic parenchymal cells, which is subsequently then secreted entirely into the bile. And that's dose and time dependent. And probably one of the most frequent questions people ask is, well, when do I give this and how do I put this? And if you look down here in the graph on the right, you can see the cumulative proportion of ICG and bile on the y-axis and then the time in minutes on the x-axis. And you can see it's a pretty steep curve. And really by about 20 or 30 minutes, you already have 50% excretion into the bile. And I think that means a lot in terms of timing, meaning that you don't need a ton of time. You don't have to prepare patients for days or even hours beforehand. And many of the times when people utilize this, they'll give it to a person right in pre-op, before induction, or have anesthesia give it right before induction. So then by the time, the whole rigmarole happens of intubation and prepping and draping and scrubbing, you're pretty much ready, you're pretty much ready to go. Caveat that is some people less commonly inject it straight into the gallbladder to get kind of a different, almost like in a cholangiogram fashion, and that you can do obviously right away. And there's a bazillion uses for ICG and different times that you would look for the absorption, but we're just going to focus on the biliary excretion now. And essentially what it does is it absorbs light in the near infrared region. And you can see, if you remember this from physics, there's been a lot of physics here tonight. And for those people who love physics, I hated physics so much. I was so bad at it. So I'm so happy to see this again in my slide, because I feel vindicated for having to take 2 semesters of it in college and then never see it again. So for those of you who this triggers, I promise it's my only physics slide in the night. But essentially, I think it's important to understand this. And so basically what happens is it absorbs, and then it emits a fluorescent light at a slightly longer wavelength that then can be picked up. So again, it's really interesting, mainly because, there's no radiation, there's not a lot of tips and tricks, there's not a lot of rigmarole around it. And then as I'll show you a little bit, really it's a special camera. And for those of you who do robotics, it's already installed in the robot. It's something you probably hear of called Firefly, where you just toggle back and forth and you can look, and it's a great adjunct. And Dr. Bloom talked about this a little bit earlier, like, why do we even care and why do we even want to do it? And I think it's because, we're still not doing a great job. And if you look, we've kind of hit the flat of the curve in terms of quality improvement with cholecystectomy. We had a bile duct injury rate, then we started doing laparoscopy, then we kind of flattened out. Now we're doing robotics. And I think we've all seen some of the papers that have come up that have seen, again, an increase in bile duct injuries, likely with the new technology, coming out, but we're not getting better. It translates into a lot of injuries. It's the #1 litigated. I mean, Matt went through all the patient harm, but just for clinicians to know, this is the #1 litigated and won lawsuit is around this. And it's really just the key contributor to healthcare costs and adverse patient and surgeon outcomes. So technology that helps improve that safety is really effective. So what does this actually look like in the operating room? And this was courtesy of Jin Yu, who's a surgeon at Duke, and he gave this picture to give a little bit of kind of what this ends up looking like. And the nice thing about this modality is that when you toggle through the different lights and the different elements, you can see different things. So this in the top left corner is what we would see sort of as a natural white light. What you're probably used to is probably part of your standard cholecystectomy. Down here, you can see it's almost like a vascular view. I find this actually very helpful. If I use it, it can help distinguish vascular structure. I don't know if any of you ever play the game of, we never name the structures, but you look at the structures and sometimes they're smaller and you're like tuber duct, and sometimes toggling back and forth can help you with that. And then down here, you can see in the near infrared light with this green light, you can see the excretion, and you can see very nicely that the bile ducts kind of light up and you get a better roadmap to that anatomy. And if you look at this real time, as you're looking at sort of all three different landscapes in the same element, you really get a nice sense of the biliary anatomy, and you can see it in the different thing, but you can also see, as compared to white light, how this really enhances and helps you understand your dissection and gives you sort of a roadmap. So many benefits here, easy to use, right? You're giving it to your patient before surgery, somebody's administering it ahead of time. You have your camera, or you have the Firefly, which is already built in on your robotics. You toggle between the lights, you can go back and forth. You don't need to, when they first started coming out with this and we started using it, oh gosh, like the first systems, you unhook and rehook all these cameras, but you don't need to do that anymore. Everything is pretty streamlined, and there's several companies that do it. It's multi-purpose. As I mentioned today, we're talking about it for biliary disease, but a lot of persons are talking about this for hepatic tumor demarcation, ureteral identification, blood vessel identification, pelvic lymph node biopsies. So for those of you who know, like if you're giving a value proposition to a hospital and trying to figure out what kind of capital equipment you want to be in, whatever you can bring in that has many purposes across many divisions and many specialties is always more attractive. And it's incisionless, right? So one of the issues about IOC is if you're using it because you don't know the anatomy, right? Then the catch-22 to that is you've injured the anatomy that you don't know what it is in order to do the cholangiogram, which may or may not be okay if it's helping you identify sort of a problem, but it's kind of nice to have something that doesn't require an incision to be able to better identify the anatomy, because you haven't injured anything before just by using it. But I think there's some limitations, right? Real world performance. I think of many of the videos I showed you were really pretty. They're the robin's egg blue. It's not what Adnan got tonight on call or what anybody's going to get in, you know, the next couple nights. And they're all real world circumstances where you have necrotic or gangrenous cholecystitis. You have obesity with a lot of, you know, thickened tissue or fat kind of encasing the gallbladder. And if you look at some of the work from Rosenthal, they ran a couple trials down there. They seem to suggest that there is some benefit and that they can be used in this real world conditions, but I think the jury's still a little bit out on that, and how useful it is, again, when you have a lot of these hard circumstances is unknown. The second thing is that, you know, you've heard a lot of people talk about ultrasound and intraoperative cholangiogram, and with both of them, it gives you sort of two pathways. One is anatomic identification, but two is the ability to identify and with IOC treat, you know, choledocholithiasis. One of the downsides of this technique is that you really can't identify stones with it. And then one other comment on the real world performance, if you have obstruction of your cystic ducts, then your biliary tree is not going to fill. So if what you're looking for is, you know, diagnosis and potential treatment of choledocholithiasis or other things, this is not your right kind of tool in your toolbox. This is more for safety and anatomic identification. And what would a talk in 2024 be without talk about healthcare costs? I think we talk about this sort of all the time. You know, each one of these bottles costs $50. You know, you give it to every single patient, it adds up quickly, especially when you think about the margin and the reimbursement for a cholecystectomy isn't really that much. And, you know, in many places is a money losing operation that you're now adding incremental cost to. Contraindications and cautions, you know, obviously anybody who's allergic to iodides or iodinated imaging. Historically, this was a pregnancy class C classification, but that's changed over time. So the belief is that this is safe to use, you know, in persons with pregnancy. And then it does tend to interact with heparin preparations, including sodium bisulfate, and it can reduce the absorption peak of the ICG in the blood. And then radioactive iodine uptake studies shouldn't be performed for at least 1 week after ICG administration. So nothing really bad. You know, I'm sure rarely someone can go to anaphylaxis, but it's a very well tolerated medication, and really it's pretty, it can be used in almost every single population, including renal failure, hepatic failure, you know, anybody can have it. So this is not the type of night I'm sure anybody wants to see data or look at anything, you know, given it's the end, but I'd be remiss to not just share a couple things. There have been randomized control trials looking at near inflorescence. The biggest issue, as everybody knows here with any type of trials, it can never be powered to the outcome of interest, right? Everybody wants to know, is this going to prevent a bile duct injury? And there's sort of two issues with that, right? One is bile duct injuries are pretty rare. So if you're powering to something that happens 4 in 1,000, you need so many people in each arm that it becomes completely undoable. So we tend to look at surrogate proxies around safety to kind of get at this notion of, are we doing safer surgery that could prevent a bile duct injury? And then the second thing is it's really hard to characterize and capture bile duct injuries, because what is a bile duct injury? Is it, you know, a small thing that's treated by ERCP, a small leak, a major reconstruction? And so when you're going through Medicare data, like Dr. Bloom showed you, you know, you're using like a series of codes to like Sherlock Holmes together what happened to the patient, which may or may not be sort of as accurate as you want. So the bottom line is, no matter how good our study is, we can never power them to the outcome of interest. So we do the best we can around surrogate outcomes. And that's why you'll see some of the outcomes here, which are really around dissection times and visualization, because it's what's feasible, pragmatic, and practical. And so back in 2019, they published a randomized control trial of white light to near infrared. It was a single blinded trial. 321 people underwent the near infrared technology, 318 white light. And again, the primary outcome was the detection rate for 7 biliary structures before and after dissection. Pre-dissection detection rates were, again, superior in the near infrared group for all 7 biliary structures, but there was no difference post-dissection. So what does that tell you? It tells you that it helped people identify structures sooner. But, you know, once you did a good job and got all the structures out, you didn't really make a difference, which makes sense, right? Like once you've cleared the anatomy, you should be able to know what you're sort of looking at. Again, here's just kind of a graphic formation, also looking in the not overweight, overweight, and obese. And it won't surprise anybody that, you know, it was a little bit easier to do in non-overweight patients. And as we kind of went up to overweight and obese patients, that detection ability went down, but was significantly better than white light alone. So again, confers some advantage. However, how much of an advantage is relatively unknown. And then this was another graph, again, looking at minimal, intermediate, or severe inflammation. Obviously, in minimal, it's going to perform a little bit better than white alone, but there is still some benefit in intermediate. And then in severe, it starts kind of coming down. Again, the majority of that benefit happens before the dissection, not after the dissection. But I think that that's also probably most important, because that's when many of us kind of anchor on what structures we think we're seeing or not seeing. And it also helps in terms of the dissection plane, because, you know, as many of you know, a lot of injuries happen because we start a little bit too low, we get confused, there's a lot of contraction, we move down more than we should, and then by the time you even realize it, it's a little bit too late. So again, anything that can help keep people on the right plane, keep people visualized, is always helpful. You know, there was another, and then, you know, in 2021, something else came out, and it was a meta-analysis kind of looking at all the data and combining all the data. And the pros of a meta-analysis is it's the best thing you can do for a systemic review, where you take like all the information and put in one place. The bad part about a meta-analyses are like garbage in, garbage out. So you have to just kind of take everything with a grain of salt, you know, because it all depends on the strength of the data that's feeding it. So they found about 5,000 abstracts, and essentially, you know, went on and included very few and had a lot of strict parameters. But they ended up looking at the number of bile duct injuries and the number of open conversions with and without ICG. And they did see some difference in some protective benefit for ICG in terms of conversion rate, but not really so much noticeable with the bile duct injury prevention rate. But again, you have to remember, if there's only 1 or 2 injuries per trial and only so many people, it's really going to be hard to kind of pull that out. And then finally, most recently in 2023, was the result of the Falcon, which was an international multi-center randomized control trial where they enrolled about 300 patients in the near infrared, and 143 in the near infrared and 151 in the conventional group. They found that the time to get to the critical view of safety was a little bit shorter for the near infrared. Again, pretty consistent with the data, pretty consistent with the literature, helping people identify structures earlier. There was no difference in length of hospital stay or occurrence of postoperative complications. And again, the conclusion of this big trial was that it helped better identify relevant biliary anatomy. So I think our key takeaways is tonight, you heard a lot of people talk about different tools in the toolbox to help enhance the safety of cholecystectomy. I think it's really important to understand the studies that you're doing, why you're able to do them, what they're going to show you, and sort of the importance. For ICG, it's safe. It can help, you know, identify different anatomy. It's easy to use. It's radiation free. It's a little bit expensive from the dye, and obviously the capital expense, unless you have a robot with Firefly. But, and you know, we always need more data and efficacy in difficult gallbladders, but just the caveat being, unlike the other tools, This will not help you identify choledocholithiasis. You really just want to understand and make sure that we're using it just for anatomic identifications. So with that, I'll say thank you, and I'm happy to answer any questions.
Okay. What a great bunch of talks. It gives me the ideal time to do something, which is to talk a little, just for a moment before we go to the questions. I wanted to share something. Let me go back. Whoops, I missed it. Okay, there we go. So we've got, I don't know how many attendees we have on the call, but I think I was blown away by the quality of this session. And so it's an ideal time for people to think about joining SAGES. These are some of the benefits here, that there are discounts for the SAGES annual meeting. There's loads of educational material that's produced and made available. There's access to 7,000 colleagues, and the more the merrier. The more members we have, the better we are as a group. They get an online subscription to Surgical Endoscopy, which is a premier journal in the area of laparoscopic and robotic surgery. Then there's members-only research grants and all sorts of opportunities to participate, giving these sessions, right, as members of the panel for these webinars. So you can see what the vision is. Great. Reimagining surgical care for a healthier world. We want to innovate, educate, and collaborate to improve patient care. I mean, that's like, motherhood and apple pie. Well, of course, these are the things that we're interested in. And it's an inclusive organization. We want to take in members from every specialty that has any interest in learning about what we have to offer to improve patient care and minimally invasive surgery. And by the way, that includes flexible endoscopy. So these are the various membership categories. So everybody's welcome. And to learn more, go on to the SAGES website and look at the membership opportunities that are available to you. So, but I think it's a great time to advertise for that, because you all did such a beautiful job. I hope that the attendees, A, have some questions, and B, appreciate the quality of what just took place, and share it with other people who also might want to join the organization. Now, so what do we have for questions? Is it Betty? I'm looking around. I'm trying to find where the questions are. I know that we asked a few. Dana put up a little question of her own about how many people are getting to do IOCs. But I don't know. There's a question and answer thing here, and all that's in there really are answers to the question that Dana asked. And there are some questions here. For instance, Rafael Vazquez asked, "Is 2.5 milligrams IV is the same as good as 5 milligrams of ICG? What is your preferred dose?" So that's a question directed to you.
Yeah, I use 5, but 2.5 is probably fine. I think it's a little bit of voodoo with the dosing. If you're getting good biliary excretion and you can see what you need to see, I don't think that it matters for this.
I heard that if you give a quick jolt of, let's say you gave 2.5, if you wanted to look at the arteries, and I have no idea if this is true, but if you gave a quick jolt of 2.5 more, that you can visualize the arteries rather quickly. You're not waiting for the pickup in the excretion by the liver. Is that true? I don't know.
It is. I mean, it depends what you're looking at, and different times have different absorptions. So if you're looking for arterial, then you want to give it right away so that you can see it. And then, obviously delayed and waiting for the biliary excretion. So again, it just depends on what you're looking for and what you're looking at. A lot of times it's used as kind of that jolt when people are doing pelvic dissections or pelvic lymph node dissections, where they're trying to get an idea of the vasculature. Or I've even seen people use it to try to identify the ureters and try to get, them out. And again, it just depends what you're looking for, the timing and the dose.
Okay. Now, we don't have any more questions. Are there any other questions that folks have?
Actually, I would love to
Pretty
ask
soon I'm going to ask
Sal.
the faculty to ask each other
Yeah,
questions.
I
That's what,
I would love to ask Sal a question. Sal, you mentioned about and I'm embarrassed I didn't know this considering I use C-arm quite a bit
can you
about
hear
the
that, Dana?
oh, can you hear me?
Yeah,
Please
yeah.
repeat it for me. I couldn't hear Adnan, so
Can you guys hear me?
they can.
Okay.
I'm back to my thing. I can't. So maybe you could repeat the
No,
question.
no worries. Yeah.
One of the questions.
In terms of the C-arms, are all C-arms where the receiver is on top? I mean, it sounds to me, or are some of them the other way?
No, I think as far as all the ones I know, the
Wow,
design is the receiver is on top. Yeah,
that's incredible.
that's
Yeah.
just that's just the basic
It's
design.
embarrassing considering how many times I've used it, and I actually thought that some of ours were the other way, but I guess not. So
And now some of the what's changed over time is not so much just the receiver itself, well, not the intensifier, but how the image is received. Because now a lot of some of the CRMs are also going to digital platforms as well, which is kind of moved away from the intensifier. Now it's all become like digitized. But the basics is the same in terms of like the radiation source. Most of them is coming from below the patient. So yeah, so it's a little bit of a, kind of like I said, if you want to actually block off very specific parts of the patient's anatomy, the reality is you actually have to put the lead underneath the table to block that, exposure. So kind of interesting. Yeah. But actually, well, now I have a question for you, Adnan, too. Ultrasound. Do you foresee ultrasound, you think, in the future, basically taking over the role of intraop cholangiograms? Do you think we'll get to the point where ultrasound can identify the CVD stones, clear them out, and then we kind of get a pre and post imaging after, like, let's say,
I mean,
colodoplasty?
it's a great question, and Matt, I'd love to know your thoughts on this. But the reason, maybe I'm just a little too lazy, but to me, I find I used to use a lot of cholangiogram for bile duct clearance and things like that. Now still use cholangiograms for, but I use it when I'm doing liver surgery. But if I'm doing bile ducts, I just prefer ultrasound just because it's just easier. I don't have to ask anybody to be there, and I've just gotten so used to it. But I don't know if it would ever be a replacement. But for me, it's just easier. But I wonder what you think, Matt.
Well, it's interesting. Our liver surgeons don't use it at all for their gallbladders. They laugh at us.
Really?
Yeah, I don't know that they're using ultrasound either. They're not using intraoperative imaging for their gallbladders. They just use the force and
Use the
get it
force. I
right.
love it. But they use ultrasound for their liver surgery,
For their
I'm
liver,
sure.
certainly
Yeah,
for
of
their
course. Yeah,
Let me
yeah.
ask you this though: how useful is ultrasound imaging to work out aberrant anatomy?
Oh, it's a great question. No, aberrant anatomy with respect to a cystic duct, it's
Yes.
actually pretty good. Aberrant anatomy with respect to common bile duct, it's excellent. It's really excellent because, I can just basically flood the area with some saline and I put it on there and I just put some color and I know exactly what's an artery. I know exactly what's a portal vein. If I have any doubt, I put a Doppler signal on it and I get the Doppler wave. It's like zero guessing. But the cystic duct sometimes can get tricky because it's small and it's convoluted.
Right.
But the common bile duct is super easy. Yeah.
What's the you think average number to become proficient at this? Like, if we want to start introducing this into residency, any general idea in terms of the number of cases, the learning curve to get proficient at it?
For cholangiogram, you mean? Or for ultrasound? Oh,
Ultrasound.
yeah. I mean, the way I think about it is that ultrasound is not going anywhere anytime, right? I mean, so a broad-based general surgeon is using it for thyroid, using it for breast, using it, and so I think there is some transferability of comfort, right? If you're just doing it, so to answer your question more directly, if you're just doing it for laparoscopic gallbladder and bile duct, it's probably like a big number. But if you're doing it for like thyroids and trauma, like I mean, how many fast exams are they doing? I mean, they're doing a lot of fast. I think that number is small. I probably 10, 20, because they're not like oh, what's depth? Oh, what's gain? And no, they know that. They've used it in fast and, central lines. And I mean, now it's everywhere, so.
Great.
Let me see. I haven't seen anybody. Here's a question from Lindsay Cathen to Dr. Alseidi. How would you suggest going about becoming proficient in intra-operative ultrasound? I think you may have answered this just now.
I think,
use as a
there
new
are
graduate with little experience and nobody in your practice using
Yeah.
it frankly. I mean, basically this person is saying, I'm kind of alone here. Finished with my
Yeah.
training. I haven't used it before and I want to pick it up and start using it. How do I get proficient? How do I know I'm headed in the right direction with this thing?
There's a lot of courses, online courses, and if you have no clue how to use an ultrasound, then I would say take a course. There's a lot of online courses on the basics of ultrasound, and then get comfortable with an ultrasound machine. Even like I would use it for your central lines and use it for your ports and use it for your breast biopsies and get comfortable with it. And once you get comfortable with the machine, the transferability of that into the operating room is so easy. And I just showed you some modules that you can pick up, which actually can get you comfortable with kind of how to get comfortable with the laparoscopic probe. But you don't want to jump into laparoscopic ultrasound when you're not comfortable with ultrasound. And I would just go there first personally. But again, most residents are using ultrasound for fast and for jugulars and all that stuff. So I think once you get comfortable with ultrasound, getting comfortable with with a laparoscopic probe really takes like 2-3 cases, and it gets very, very, very easy.
Okay, so basically build the skill up with the more common external procedures, get comfortable with dealing with the images you get from those probes, and then go ahead and pick up your laparoscopic probe for the operating room. Okay. See, I don't know if anybody's put any additional questions in the question.
There's also like the urologist use ultrasound all the time in robotic prostatectomies and partial nephrectomies, and so it's really hard for me to imagine a hospital that doesn't have the drop-in probe and laparoscopic probe, because that's like standard care for them, and those are obviously common surgeries. So.
Here's sort of a general question for everyone, I think. Is this from an anonymous person who doesn't want to reveal their identity? Somebody had to do this, though, so I take my hat off to this person for actually doing it, which is to say, hi, thank you so much. Nice talk. Do you see any potential for new dyes to enhance visualization further? And also, what about AI-driven image interpretation and things like that? Is there a role, do you think, for that to assist the surgeon in looking at these images? I think that's, again, a little bit for you, Dr. Alseidi.
Well, Dana, I'd love to know your thoughts, especially about like antibody tagged ICG. I think that's a kind of an up and coming field, especially with respect to cancer oncology. But do I think that there is a place for AI generated assistance in interpretation? Absolutely. Like Matt showed really some awesome cholangiograms, but we know that that a lot of people have misread cholangiograms. I mean, as a person that repairs bile duct injuries, the number of times I've seen people like look at a cholangiogram and say, "Oh, it's normal," and they're missing the right posterior section. It happens, and so having that situation where you have software that says, kind of like when you're looking at an EKG, it just tells you a EKG read and says, this is what I think. It doesn't mean the machine is right, but it gives you that second opinion. I don't know, Matt, and they know what you think, and then and then see if you can say, no, I think the machine is wrong. That's fine, but at least you get that second opinion in the operating room.
Well, pretty much, though, you're going to have to document the images, right? You're going to probably have to snap a static image and have that. Maybe the AI will be good enough to look at you as you're scanning it in motion, but I have a funny feeling it's going to be better on a static image that you create and say, I think this is a stone. I think this is a duct, and then identify the duct.
Well, that's what my lab is working on right now. And we've been beaten to publication by a great group in Australia. They published in the SAGES magazine, but hopefully we'll follow up with an even better paper. But that's it. My point is that's exactly our active area of research, AI augmented interpretation of climate.
Image interpretation,
Yeah,
yeah.
that's what yeah.
I was just guessing. I didn't know you were working. That's awesome. That's fantastic. I love that.
I think everybody throws around AI these days, and it's like AI and machine learning and AI and machine learning, and there's such buzzwords and knee-jerk words. And I think we have to think about kind of what's the stepwise and what is kind of where we're at and where we're going. And there are great labs like Matt Bloom's lab and I guess the colleagues in Australia, like people like Dan Hashimoto and Amin Madani, that are all kind of looking and thinking about how do we make things safer for surgeons, but not necessarily replace surgeons in judgment calls. So when you think about self-autonomous driving vehicles, you don't go from 0 to like a self-driving vehicle all at once. You start with auto correction. Can we tell when people are getting lost? Can we tell when somebody's about to make a mistake? Can we tell when somebody's about to get into an accident, and can we prepare them? And so when I think about AI and adjuncts in the operating room, right now where I think we are is trying to understand the surgeon cues for when mistakes are going to happen, and how do we auto correct those mistakes versus just telling somebody how to do, an operation, because I'm not sure we're at a point yet where a machine could fully, do things. Maybe that will come. I don't know. Maybe we'll all be replaced by machines. Who knows? And then the second point is, I'm sure there's going to be other dyes. I'm sure there's going to be, and I mean, there's no shortages of things that get developed every single day. And there's no shortage of things that get developed and then have evidence on it. But what we do see is a lack of implementation of those things. And sometimes it's time and material, like IOC. Sometimes it's cost barriers, sometimes it's knowledge barriers. So I guess my point here is, we create a lot of this technology and there's all this stuff coming on and it's in the hands of a select few, but how do we promote its adoption and dissemination into actual practice? And if my goal is whomever is in this audience just leaves with like a burning desire to do one thing they hear today, to go home and to teach others or to learn how to read an IOC or do that, I think that that's great as more of these things come down the field, because eventually you're going to have to figure out what you want to do. But if you don't know what's out there, it's hard to kind of choose among them.
Yeah. And if I could just add one last comment, that I think, for the most part, at this moment in time, nothing really replaces the human ability to understand what is normal and what is abnormal. And to understand what is abnormal, you need to see a lot of normal anatomy. And I think that falls on all our shoulders in terms of being responsible, in terms of making sure residents do a decent amount of intra-op cholangiograms, giving them the ability to one, perform them, two, to interpret the findings and really understand what is normal anatomy. So that at some point in time, they can, if they're in a situation, they can really understand what is abnormal. Are they in the wrong duct? Did they create an injury, etc.? So I think that's also another good point to take away from this is, as a residents or anyone else on this call in the audience, go to your attendings, go to where you're training, and just ask them, say, can we start doing some more intra-op cholangiograms? I've had, our program too, I've run into some senior residents where I was the first one to do a cholangiogram with them. And I think it really truly is our responsibility to really it's a dying art, unfortunately, and we really need to bring it back to the forefront. I think it's important, especially with this huge movement toward cholecystoscopy, and we're training all these individuals to perform cholecystoscopy. But at the end of the day, the foundation of that is understanding how to do intra-op cholangiogram, how to understand anatomy, and what is normal and abnormal. So,
It's pretty clear that if you're going to get into that neighborhood of surgical treatment, you better be able to image the bile ducts, absolutely, and establish that it's even safe for you to make that kind of a move in the operating room. When Matt, I thought Matt's figure, I think you said about the normal anatomy, in quotes, the netter anatomy is 17%. I mean, so people should really essentially expect that they've got abnormal anatomy. And I think they get into trouble by trying to make what they see in front of them look normal. The fact is, it can't look normal because it's not normal. And what they're going to do is cut something bad while they're trying to endeavor to do that. But I love the complementary role of the ultrasound is pretty amazing. I think in these gallbladders where there's such chronic inflammation up at the ampulla, sort of one of the ABC of Maritzi syndromes, right? It'd be great to be able to look up there and just say, I'm leaving. I'm not going any further, not making another cut. I'm following Strasberg's advice and just going to scoop the stones out of the gallbladder, put a drain in, and get out of Dodge. Because the consequences that were brought up about the long-term effects of the bile duct injuries, they're just not worth exposing the doctor or the staff and the patient to. No, if it would help me get out, that would be enough of a reason to learn the ultrasound. If I could look in that area and see something and say, get out, quit this case, that would be wonderful. Well, anything else that anybody else would care to bring up? I don't think we need to show that Kumar cholangiogram movie because you did a beautiful job, Matt. I think you kind of did it.
That was a really well, very well
clamp
nice.
on the gallbladder, partitioning it and sticking a needle in the ampulla. I mean, the same thing essentially. So, okay. Well, if there's nothing else,